Then we're going to look at the challenges between client and therapist in terms of relationships, and just to be precise, kind of patient-centered treatment care. And then we can navigate through the challenges, and we'll have a RAP plan. A RAP plan, basically, I put it in a simple word, like your own will when you are leaving. Especially, I mean, for example, we have had people writing wills, and they say this is how things has to be when I'm gone. But now a RAP plan, basically, it's stating about your own will when you are leaving, and how do you want things to be done for you to feel better and feel good and keep on moving on with life. And then we also have got psychodynamic modes or models in terms of how do we go about patients that have got these issues. So basically, we start with grief and its manifestations, and we look at grief is, how do we define it? This is the emotional reaction to a loss experienced by all persons at some point in time. So that means everybody is bound to grieve, and actually grieving is something good, is something healthy that we encourage people to be doing, especially when we have got a loss, irrespective of the size of the loss. So grief itself is an experience, and we experience this in different forms, and there might be a cognitive experiences for the grief. We have got emotional, physical, social, behavioral, and even spiritual perspective in terms of the grief. So how do we feel when we lose something? And basically, one way or another, you find that you have lost something. And when I used to understand initially about grief, I thought you need to have maybe lost your loved one to grieve, but the truth is no. Even you losing a phone, if you lose a phone, that's something that is so dear to you. You have to call somebody, and now somebody somewhere took your phone. Now you can't communicate. You will feel sad, you'll feel anger, guilty, maybe there's anxiety coming on, loneliness, thinking about something that you lost. So when we talk about grief, let's not just concentrate on losing the loved one, but think about anything that you have lost in life. And basically, I normally say, and we advocate for this course by saying, this course is meant to help you first, and then once it helps you, now you can transfer it to somebody else to help him, or help your neighbor, or help your patient with. So if it doesn't help you first, then it will be very difficult for you to help somebody else with it. So basically, when you lose something, there should be an emotional reaction. And the emotional reaction is what can result into anger, loneliness, sadness, and so forth, the shock. You see that? And the relief in terms of numbness and so forth. So those are the things that you will experience emotionally. But again, physically, what happens? So when we lose something sometimes, and this is, if at all you have lost something, you'll feel this that we are explaining here. You can feel the hollowness in the stomach, the tightness in the chest. There is oversensitivity to noise. You don't want people to talk to you. You want just to be alone. There might be shortness of breath and sensation of depersonalization. So you want to be alone. You don't want people kind of talking to you. You want to be in your own space. So those are some of the things you can feel when you're grieving. And those are some of the manifestations that we get to encounter. And those are some of the manifestations that your patients are going to come with that you need to understand and help them. And we have got the cognitive perspective. So when you lose something, and as I said, for example, losing a phone or losing even your job. So let's say around the COVID-19, so many things happened. People lost their jobs and they went back home packing, and that was the only source of their livelihood. And you come back home not knowing what you want to do, not knowing how to move on. And now when your boss tells you, hey, let me use my friend's example, Mr. Martin, think by the end of this month, you're not going back, or by tomorrow, you need to pack up your desk and go because the company is not in position to pay you. So sometimes you might think it's not really happening. You might be in a disbelief, in a confusion and preoccupation. So thinking of what's really happening at that particular time. And Also, behaviorally, you might lose the sleep or appetite or disturbances. So you might have a sense of withdrawal or a loss of interest in activities. So most of the time, people get depressed when they're undergoing such a situation. So, and socially, when somebody is in a grief state or grieving, I find they'll have different or difficulties in terms of interactions or relating to one another. Even the lots of friends that you used to talk to, you might think like, no, I don't want to talk to anybody. So it's a bit difficult for you to relate or correlate with events. And spiritually, so you'll see there's a loss of meaning, and you might think or be hostile towards God, and you lost something, you lost so many things, you lost a job, and you feel like maybe God forgot you. If you are spiritual, spirituality, people think, maybe God forgot me. So basically, when we look about all those domains, and as a human being, and as a patient that we see in on our daily basis in the clinics, we tend to look at the body and see that this is, for example, a back pain problem, and this is just the back, but we forget this is a human being, and a human being have got all this what I've talked about.
Hello, I think we got some technical problems. Agnes and JD, if you could help with that, thanks.
Continue with this. I'd love to share things.
It's not sharing yet. Not yet.
Hello, Alan. We got a technical issue. We are fixing it. So 1 minute.
All right, no problem.
All right.
Mine was still sharing.
Agnes, can you remove the presented, the shared screen, so that we can share again with a new laptop? You can just try to share with one. All right.
Yeah, I think it's done now.
Right, it's done. Yeah. Okay, then.
I think it's done.
Oh, it was simply share. Simply share.
All right.
Keep on going.
That's why the voice here.
Yeah. Just let's go. It's here. Let's go.
Take it.
So sorry for that. We have had a technical problem, but I'm glad that it's already resolved. So let's move on. So as I was saying initially about what we do and the patients that we get to see on our daily basis in the various healthcare institutions. So we need to see patients in that fashion, looking at this patient have got emotions and react to things differently. We need to understand how is this patient taking information that we give them, the education that we talk about in terms of patient education. How are they cognitively taking it? How are they comprehending the information? And we also need to understand, yeah, it's a physical body that we are seeing presenting in front of us. That that the patient is coming with maybe musculoskeletal health problems or neuro perspective, but we are putting everything together, knowing that this person lives in a society, and there's societal related issue that might be accompanying. There's the behavioral changes based on enculturation, and we are looking at the spiritual human being. So all this put together, we need to consider them whenever we see a patient, and especially right now when we have got the COVID thing around. So now, at the end of the day, we are all survivors. That's what we say. Losses come in all shapes and sizes, and there can be a loss of a spouse, there can be ending of a marriage, there's a loss. Transition from a city to city, you're going to a new place that you're not used to, there's still a loss, because you are missing people that you had already made connections within a city that you were. So that's one way of kind of losing something. And then there's transition from employed to joblessness. Again, the COVID-19 gave us a lot of troubles, and people lost their jobs, and we have got families that lost their jobs, friends, and so forth. So that's still a loss. So at the end of the day, all known as little deaths. So everything that we have just gone through there, we call them as little deaths. Okay. And let's talk about bereavement. Screen here. Yeah. So now, what's bereavement? And we talk about bereavement is an objective state of loss, the change of status resulting from a loss. So let's say if you lose the loved one, for example, if you're a wife, then you're becoming a widow. So that's like the change of state. If you had a job and you lost your job, for example, now you are jobless. So that's what we look at in terms of bereavement. So it's a sense of being deprived of something or someone you love. And bereavement also is a state of being. It can persist for months or even years. So we find people that are still staying in the past because of what they lost. If you lost a job that was just the only thing that you believe in, and now you need to change things around, you might still staying in the past for a while. Then what about mourning? So mourning is the behavioral action and integration of grief and bereavement in a ritual or culturally appropriate form. So we have got different culture, and let's say just in Africa, and I can give an example from where I come from. So the western part of Kenya, that's where I come from. And when we lose, for example, the loved one, so at the end of the day, it's kind of a ceremony, and you'll find people, we slaughter goats, chicken, and animals, and then it's kind of a last respect. So that's what happens by that, where I come from. But again, I'm giving an example from where I come from, and just in the same country, in other parts of the country, you'll find something happens, and it's not that taken the way we take it. So it's simple, fast, and then people forget about it. So actually, mourning is a ritual. So these are ritual acts that expresses loss through a task or activity, so you perform, and it can be like a private play as well, personal or group acts. So you're coming together and do something based on what you lost. So there's grief theories, and actually there have been multiple theories about grief, and the one that has been popularized is the Kolber's-Ross change of curve. So in general, theorists agree on 3 pattern stages for grief. And the first is the pattern of shock and disbelief. So you get the information, you are shocked, and you're like, no, maybe it did not happen. But at the end of the day, it happened. And then now you will get into acute mourning, you get frustrations, you might get depressed. But at the end of the day, you need to make a decision. So we need a resolution and we need to move forward. So that's actually what Kolber's-Ross theory is talking about in terms of grief. So when we meet patients that have got these problems, we need to start singling them out, and we need to work with them stage by stage and make sure that they're moving on. They're not stuck in the past. We need to move on because that's the way to do, and that's the way to go. And that's what we call complicated grief. So we have got grief, which actually we advocate for as clinicians and as people. That's something good to do, but at the end of the day, that's what we call complicated grief. So grief is a normal experience, yeah, but with this one, it's kind of the departure from the normal psychological, emotional, and physical symptoms of grief. There's kind of a deviation, and it's kind of having an intrusive thoughts. And for example, if you are at a dinner somewhere, and for example, and that day something terrible happened in your life. So every time you go back to that place, you feel like, I don't want to sit in this place because something happened that day. So it means whatever happened that day is still pushing you, and you haven't forgotten it, and it's still kind of in your life, you didn't let go. So that's what we call complicated grief. Also, more likely, this happens for people that have got some mental health issues, for example, people with anxiety and depression. So when they lose something, most of the time they tend to stay in the past. Traumatic events, the traumatic grief, there are some of the things, a few things here that people will experience. And if you've had a neighbor with this, or you yourself, or a friend, or a family member experiencing this, then this person needs help. You need to kind of get somebody who is trained in mental health to at least help them move forward and not get stuck in the past. So we're looking at preoccupation with the deceased if at all. So everything they are doing is about the deceased. And sometimes they might come in kind of saying, I am feeling maybe the neck pain, and showing exactly the place where the deceased used to feel the pain. And you start thinking about he or she is correlating things that used to happen to the loved one that he just lost, but he's now thinking that now everything is with him. So also memories will be upsetting, and you avoid reminders of the death and so forth. Sometimes people that are in that, and for example, if you lost the loved one, you'll find that you can tell people that you are talking to the exact person that you lost. And ideally, everybody in the society knows that the person is no more. So that's what happens. And let's take this and put it in terms of the situation that we are having right now, the COVID-19. And we find, for example, for those who lost jobs, I'm sticking on that because I know it happened, and it happened to my friends and so forth. And these people are having difficulties on coming back. And also people lost their loved ones in that through COVID. And you all need to put all this together and see how to move forward with them. So we have got what we call psychosocial practice recommendations of how do we recommend, especially when we get people that have got some mental health programs and we believe we can help them, or there is a window or a room for us to help. And we look at what we call intentional acts to honor the deceased or the loved one. Just that's, for example, if that is the event that they are going through. And most of the time, people will prepare food or things that their loved one used to, so we can help them go through over it. And you can see like memorializing the day that happens. Also, the creation of kind of things like family heirloom. So like nowadays, most of the people are on the internet, and we see on Facebook, if people, if they lose their loved one, they post the photos and the videos and so forth, just to get over it. And that's what is happening. So that's one way. So that is one way of doing it. Also, we need to develop skills needed by the grieved person to cope with the new life. So we want to understand, we need to put ourselves into their shoe and see how do we move forward. And that's why if this doesn't help you fast, it becomes a bit difficult to help somebody with. Also, we need to refer the client to support local grief groups. So especially if there is one here in Rwanda, or people that are attending from Kenya, there are many there. You can attach somebody to a support local group so that they can move together as a group and they heal together. So healing is the most important thing here. So we can also, if this person is prayerful and they believe in prayers, we encourage them that they pray so that they get to move on, so that they can feel better, and also celebrating the anniversaries. These are the things that help them to move on and go back to their normal life. So that was one aspect of how do we help these people. So another aspect is what we call mindfulness. So based on Bishop et al., in his journal, he says like, this is a non-elaborative, non-judgmental, and present-centered awareness in which each thought, feeling, or sensation that arises in the attentional field is acknowledged and accepted as it is. So these are intentional acts that we encourage people can do. So it's based on the religion, but it's something that is good to do. So like, there are two aspects on how we can practice mindfulness at this particular time, especially if you get people that are going through this hard situation. So there's one that is self-regulation of attention. So this is skills included is like sustaining attention and or switching attention or inhibition of cognitive process. So basically you kind of seated in one place there, meditating or just getting through events, and you want to feel good and you want something good to pass by. So you want to hang in there to sustain the attention of whatever you are experiencing at that particular time. Somehow you'll want to switch from just to wander from places to places when you are doing mindfulness. And this is also good because it helps you kind of have the balance and experience both sides. At the end of the day, we want to feel good. We want to do an act or perform an activity that's going to make you feel better. And then we have got orientational to experience. So for example, this is being curious about where your mind wanders to when it drifts from here and now, not looking to change what one feels or produce relaxation. So you let your mind go, it's wandering around. You just want to experience the good feeling about it. So that is the mindfulness. So these are some of the things that are recommended based on the evidence that they are going to help, especially people that have got some mental health problems, and especially now that we are having the pandemic. But not only now, again, it's something that we need to keep on practicing and help our patients and the people we love around. So how do you practice this? So how do we practice this? Can be done in sitting or lying down. And so you need to be like being open to expanding awareness. You want to feel things in the environment. And it's like cognitive reappraisal, so new ways of thinking about self and environment. So you want to be aware about yourself, about your mind, and about the environment around you. So, and also we have got what we call intimate detachment. So like activity, actively seek to unstuck yourself from the habitual negative emotional status. So you are feeling bad about something, but you want to feel good. So you want to put yourself in a situation by everything that is happening in your brain whenever you are doing the practice, it's helping you feel better. You want to feel good. And we've got mindful movement during usual daily activities. So you're like looking at, like, for example, in the morning, you wake up and there's activities that you normally do, and in the afternoon and the evening. So you're just wondering about all those activities. And the whole idea is to make you feel better. So that's one of the practice. And again, according to Bruce et al. In 2015, all these acts, they are non-judgmental. So you need to be being in an impartial witness to your own experience without premature conclusions. So you want not to judge yourself or judge what is happening at that particular time. And you also need to be patient, letting things unfold in their own time. Also, when like in a beginner's mind, so you need to have to be receptive in a new possibilities and not get stuck. So the whole idea is we want to move on and we want to feel good and you want to make people around us feel better. Also, we need the trust. So developing a basic trust in yourself and your feeling, that's something good. You need to trust yourself to move on. If you don't trust yourself, it becomes difficult to move on, especially if you get somebody as a patient who have got the same issues. Try to educate on that and tell them they have also need to have self-confidence and trust themselves first. And then you will help them walk through the process. And also, it should not be thriving. So you need to pay attention to how you are right and how, and now, however, that is not. So like, don't just push things in the other way. Just take it slowly. Let's keep on moving. Accepting is also another super important thing. Seeing things as they actually are in the present. So don't try to think about the past. Ask the patient, yeah, I know the past is the past, but we need to move on. And when they are meditating, they want to be in the present. They want to feel the environment. They want to understand their body, their minds, and everything. And then letting it go is also another good thing that we advocate for. So let go is a way of letting things be, of accepting things as they are. So you need to accept what is happening. Sometimes you ask questions, why me? And patients will ask that, why me? Why me? For example, I've been having low back pain for 10 years, why me? Or I've been having this and that happening in my life, why me? So such questions arises, but how we address them matters a lot, and how we capture the stories. Actually, the most important thing for us as clinicians is everything is hidden in the stories. So even whatever I'm talking about right now, it's based on the stories. If we don't listen to the patient and get their stories right, then it will be a bit of difficult to even help them, because you really doesn't know what is going on at that particular time in their life. So we always want to take stories, understand them, and also let them understand you as a clinician. So most of the time, me as a clinician or you as a clinician, you want to say you're on top of the game, you know everything. But the truth is, you know about your body more than you know the body of your patient. You can figure it out things, but you might not understand what is going on, but he knows his body or she knows her body better. So basically we need the stories, and the stories are super important for us to keep on moving and even helping the patients. So this slide is just kind of how you will let your patient know if you chose like mindfulness is a form of practice that you want to give them to and help them. So this is how you're going to guide them. So you'll see there's breathing in and out, and there's thoughts of feeling, sensation, and maybe for positive, sometimes they will feel neutral sensation. Sometimes they'll be on the negative side. They might see things or experience things that they don't want even to see and hear about. Those are some of the things that they have to acknowledge, and we have to take through with them. And also, you will encourage them to have to bring their mind to wander. So bring yourself back to the present. You are in the past. Let's get out of the past. Let's move on. Let's make things happen. And they have to be conscious of silence, sounds, and stillness. Actually, when you are meditating, if you choose like mindfulness as a form of strategy that you are going to use and help the patient. So all those things you have to let them understand. And you're like, can you feel your hair? So through the process and your clothing and the flow. So for example, if I'm guiding you through wherever you are, and I say, let's meditate for a minute, and I can take control and take you through. And I'll just say, so wherever you are right now, I want you just to sit comfortably in your chair and keep on breathing in and out. And once you're done that, you can close your mouth, your eyes, and just stay still. And I can take you to the ocean and feel you are at the beach. And I want you to feel the breeze at the beach. I want you to feel the water waves. And keep on breathing in and out. And then open your eyes. So you can guide your patients that way based on the situation, based on what you want them to feel and how do you want them to bring them from the past back to the present. So you can do it either in sitting or standing. So the first time I did that meditation, when we were teaching somewhere, somebody says, oh, I felt like I'm stepping in the water. Just by the virtue of telling them, I want you to be at the beach, at the coast. And actually at the coast, we know there's sand and there's water and so forth. So it depends, but it's good to guide them. So this is what we call cognitive restructuring. And actually, this helps us again to see the positive part of it and forget the negative part. But if you're advising your patients on cognitive restructuring, so we are looking at, we need to consider time and contextual changes. So at what particular time are we and the context of the story? What are they struggling with? Is it relevancy at that particular time? So we need to look at that. So, and then we need to consider the positive effects of the experience, asking, did you learn anything out of the situation or the context? Always, never all, but nothing viewpoint. So at least they need to have captured something and to keep on moving, and then recognize your negative tending thoughts. So it's good also to know the bad side of it, the negative thoughts about it. If you don't know the negative, again, moving forward towards the positive might be a bit difficult. So we need to have all situations around us. So for example, I have an example here, and we are looking at an event, and you want to lose a half a pound. And these are two ways here. So we are looking at the dysfunctional thoughts, the bad side of it. What's the point? I will never lose the weight. So you when thinking about you want to lose the weight, but you've got a negative thought here, asking you, what's the point? I will never lose weight. So maybe everything you're trying to do, you might never even lose that weight that you had planned to. And the consequences is, it's going to reduce your effort. It's going to make everything difficult for you to move on. One, because you have got the negative side of the story, and you feel that everything that you are doing, maybe it's not going to happen. And this can also be a really example of the patients that we give some musculoskeletal exercise to do at home. And sometimes they're like, anyway, I might do it or not do it. And even if I do it, is it really going to help me? I've been having this pain for the last maybe 10 years or 5 years, doesn't really matter. So that also depends. But now let's look at the the positive side of the story and the functional thought. So this is just a temporary setback. So you're like, I've got some weight, I've added weight, yes, but now if I have added weight, this is just a setback, a temporary. I'll get there eventually if I just stick with it. So if you stick to the plan, stick to everything that your trainer is telling you. So for example, if your patient sticks to what you are educating in terms of patient education and tell him, hey, you are diabetic, and now you need not to take a lot of things that can bring your life into another, affect your life, affect your well-being. So some of them will say, anyway, I'm diabetic and I've been told ABC about diabetic. I've had different information about diabetic, and anyway, let me just do what I feel is good for me. You see, but if there are people that they are on the kind of positive sides, they're going to say, hey, it's just a temporary setback and I'll get there eventually. And the consequences is the increase, there's increased or some effort. So they have got to do something that they feel or they have been told is good for them and keep on practicing. So that's about cognitive restructuring. So we need to be able to educate our patients, and not only the patients, the people we live with, our friends, in some of the things that we feel they're not, they have to be done in this way and not that way. So I'll hand over to my colleague, Martin, to go on and enjoy. Thank you.
Big thank you to Shadrach for that wonderful presentation. We do apologize for the hiccups in terms of the technology bit. But let's proceed. I hope that first part of the lecture got your minds shifting from different points of directions, or even having a paradigm shift already, and hoping that you've also picked up some of the few things that you need as a clinician to help you as an individual, but also help your patients. And I would like us to look at this presentation from a burnout point of view. A lot of the clinicians, COVID-19 did expose some of the loopholes in the medical sector, where we do have a lot of those in Africa, and we, on a day-to-day basis, experience medical burnout that most medical professionals don't really want to talk about. Let's talk about resilience and what it means and why it is important that as healthcare professionals, we build resilience, all right? So there was a research done in China when COVID-19 just came around, and they're looking at resilience in Wuhan during COVID-19 pandemic. And they did it on 114 non-local professionals. What they did find out was physicians had the highest resilience as compared to other medical professionals. The support staff, stroke the technicians, did have a high resilience as well. Nurses did have the lowest resilience, and I can, from my experience in clinical practice, we tend to see, even in a hospital setup, a lot of the nurses tend to have more of the musculoskeletal problems. So you tend to see a lot more nurses in clinical setups being treated for neck pain, low back pain, foot pain, or even hip pain. And I guess maybe this is because of either the workload that they do or the continuous bullying that you get in the healthcare professionals, in the healthcare professional system. And respondents differ significantly in education, levels of anxiety, depression support provided by the hospitals in which they were. So I think for you to build resilience, you must have had an experience about something. And I can say for a fact, I can give an example of Africans are very resilient, considering the working environments that we are in, considering the environments that we live in, considering the salaries or the wages that we get as compared to other healthcare professionals from different parts of the world. And a lot of this is built out of something that we've experienced, we've experienced for a long period of time, to the extent that it is not surprising anymore, right? Resilience correlated positively with active coping styles. So for you to be resilient, you must have had certain ways of coping with some of the problems that you get into on a day-to-day basis. It's correlated negatively with anxiety and depression. So if you've been somebody who has had anxiety, panic attacks, for example, or you've suffered depression at some point, your resilience levels are a little lower compared to other people. Management should develop psychosocial interventions to reinforce resilience during highly stressful or prolonged emergencies. And this is something that we should start thinking about as clinicians or as healthcare providers in Africa. We need to start talking a lot more about our own mental health status, our own mental health hygiene, and our abilities to cope with the long hours, the long working hours, the number of patients we get to see on a day-to-day basis. So what is resilience? What is the definition of it? According to Kunza and others, they define resilience as the maintenance of quick recovery of mental health during or after periods of stress exposure, which may result from a potentially traumatizing event, challenging life circumstances, critical life transition phase, or physical illness, right? So sometimes we have to move from one point to another. You have to shift from one job to another. Sometimes you get demoted, sometimes you lose your job. So it must have come from an experience that you've experienced, that you've undergone within a period of time. And yeah, how do we prevent burnout among healthcare professionals? So we look at resilience training, increased resilience. So if you're trained in how to cope with certain negative effects, for example, I remember the first time I lost a patient in the hospital. And of course, by me losing a patient, it was myself and other medical team and the other medical team that was there in ICU at that particular time. And at that time, I was in my second year of college, and I was just sort of doing my rotation in the ICU department. That was a very challenging experience, but with time, you tend to see a lot more deaths, all right? And in as much as we healthcare professionals do our level best, in as much as we, as healthcare professionals, do our level best to keep our patients alive, we lose some of them. And sometimes it's not our fault, but you tend to move on a little bit faster compared to the first times you tend to see your patients die. There was little or no evidence of effectiveness of anxiety. Can we mute our mic, please?
Abantu baba unmutinze bakaba bari if there is a distractions between the presenter, please mute your microphones. Thank you. Sorry, you can please continue.
It's okay, thank you.
mwakongera mugasubiramo ko njyewe ntumvise.
Sorry. Can you please continue? We are sorry for the disturbances. Hello, Jedi. Hello, Agnes.
Oui, allô?
Yeah. I don't know what happened to the presenters. I think it's because there's a lot of commotion and disturbances. We lost them.
Okay, let me call them.
Abantu bari kuri unmutinga, please, don't please mute your microphone so that we can be able to learn something. Thank you so much.
Aaron ngiye kwanimutinga bose kugira ngo bamwe babashe perezida abashe kuvuga ariko turi twongera tubamuting.
Okay, nta kibazo.
Did you know that?
Yes. Hello, can you hear me? Sorry, I got lost
Yes.
for a few minutes.
Yes, we can hear you.
Okay, yeah. As I was saying, going back to the last 2 points, there was little or no evidence of effectiveness of this approach in reducing anxiety, and there's very low certainty for improved quality of life. So it doesn't really matter how resilient you are, but if you're constantly exposed in an environment that is always forcing you to be on high alert for one reason or another, that reduces your quality of life. So my advice is, let us try to find environments where we are appreciated as providers, and environments where they appreciate the type of healthcare provision we provide, but also provide enough healthcare providers to manage the burnout that we experience on a day-to-day basis. So what are some of the coping methods? And Shadrach did mention meditation as one of them. So physical exercise and physical activity is one of the best approaches that you can use when it comes to coping with mental health issues. Mindfulness and meditation, some of us do this. Some of us feel that this is not an African process, but I think we as Africans did practice meditation aspects, only that, you know, it looks like yoga. So most of us try to do yoga at one point or another, some of us don't. Imagery, this may be guided or solitary. So if you look at imagery, it's, so I've been to different clinics where they've started the use of, introduced the use of the VR system, where you have your patient kind of like put on some sophisticated goggles, and those, the goggles introduce them into a different environment. So if you're a stroke patient, he's introduced into an environment where he can actually initiate activities that will tend to trigger certain areas of the brain to use the left arm if he had a right-sided stroke, for example. All right. Relaxation music. Music is life. That's what I tend to say. Listening to music is part of relaxation. Africans have always had really beautiful, relaxing music, and we can use that as part of the meditation process. Prayer and religious practice. Social support group, finding someone to share your experiences with. This could be colleagues, friends, family. And massage therapy is also one of the useful tools for helping people recover from mental health issues. And these are just links to different music that you can use for guided imagery if you're interested in that. So let's talk about the Wellness Recovery Action Plan. This was It was a self-designed prevention and wellness process, and that anyone can use to get well, stay well, and make their life the way they want it to be. It was developed in 1997 by a group of people who were searching for ways to overcome their own mental health issues and move on fulfilling their life dreams and goals. It is now used extensively by people in all kinds of circumstances and by healthcare and mental health systems all over the world to address all kinds of physical, mental, and mental health and life issues. Now, this is something that you can also download off the internet and share it with your patients who have had chronic pain for a long period of time. And I introduced this into the clinic that we work to kind of help our patients have like a better guided way of addressing some of the problems, not necessarily mental health issues, but also pain. All right. Now, let's talk about recovery. What is it? And what are some of the aspects of recovery? For you to recover, there has to be a message of hope. All right. And a message of hope is a message that we use a lot with cancer patients. So people who experience mental health difficulties get well. They do. They stay well and go on to meet their life dreams. So there's an element of hope. So it's not like in a lot of times in the African setup, when you ask the patients, or when you ask your patients if they're depressed, the outcome is not usually a nice one. So patients tend to kind of like get really mad at you for putting them in an element that they don't belong, right? So let us start having this conversation on mental health hygiene, mental health awareness in medical professionals and also in our patients. Another part of the recovery is personal responsibility. It is up to you, with the assistance of others, to take action and do what needs to be done to keep yourself well. Some of us lost our jobs when COVID-19 came around, but we took a different step in terms of ensuring that our families did not go hungry, ensuring that we look for a different job in a different hospital, for example. So there's that aspect of personal responsibility, and you tend to have a lot more good outcome with patients who take their pain as a personal responsibility to get better. Education, so learning all you can about what you're experiencing so you can make good decisions about all aspects in your life. Self-advocacy, so effectively reaching out to others so that you can get what it is that you need, want, and deserve to support your wellness and recovery. And support is very important. So let's look for support. Let's support each other as healthcare providers, cutting across the board. So the toolbox, the wellness toolbox is ideally, an aspect of a daily plan where you describe yourself when you're well. So you have a list of, this is me when I'm at my element, this is me when I'm at my A game. And then you do the things you need to do to maintain that element, all right? You have a section where you can list your stresses, where these are external events or circumstances that if they happen, they make you feel uncomfortable. And these are normal reactions, but if you don't deal with them in some way, they may actually cause us to feel worse. So you can imagine a glass of water. So if you keep pouring water into a glass, it gets to the extent that at some point it starts to kind of pour out. So we need to understand our stresses and we need to know how to address them. And we need to have like early warning signs. This could be internal, this could be subtle signs that let you know you're beginning to feel worse. You're reviewing your early warning signs regularly and helps you to become more aware of them and allow you to take the action before they worsen. And sometimes it's important to crisis plan. So we lost our jobs not knowing what was the next aspect, right? So crisis planning is like savings. So somebody who was saving money in his previous employment or in her previous employment, and all of a sudden they told you job is lost, they can have a contingency plan of having financial backup, all right? And crisis planning is, what do I do when my back really hurts if I'm a nurse and I need to work with somebody else or look for somebody else to help me go through that, right? I don't know how much time we have, but I'll keep going until I'm stopped, ideally. So let's look at Taylor's intentional model. And these are relationship models that help you as a clinician to deal, number one, with your patients, yourself, and also your colleagues as well, right? And we have a client/patient-centered aspects, right? So we're looking at the patient as the focal point. So a therapeutic relationship is socially defined and personally interpreted interactive process between a client and a therapist. All right. Now, if you look at this slide, is more or less, I don't know if you guys have ever heard of intentional interviewing or motivational interviewing. This is ideally some of the aspects that come into play with that. So the relationship is different from ordinary friendships or other relationships, but both client and therapists are human beings with potential for same range of thoughts and emotions as any other relationship, all right? Now, there are certain characteristics that you experience, and they could be situational characteristics or enduring characteristics. They are not consistent with typical behavior of a client. These are situational characteristics. They represent an acute emotional reaction in a specified situation. So a client is likely experiencing pain, frustration, or stress, and judging the therapist to be insensitive, judgmental, or uncaring. And the therapist's response to these normal occurrences is often vital for the therapeutic relationship. How you respond whenever your patient is trying to attack you, for example, is very important. And sometimes this comes out of experience, or it could also come out of training. Enduring characteristics are more subtle and consistent of clients' interpersonal behaviors, not related to a specific situation or requiring an impairment, or to the environment or lack of accommodation. So comprise the idiosyncratic interpersonal profile of a client, and they may include capacity to trust, need or control, general orientation to relating ways of responding, all right? So I'll skip some of the slides and then I'll talk about different therapeutic modes, okay? Now, these therapeutic modes are ideally what you as therapists do whenever you're in the clinic. So there are certain ways of how to address or kind of help you clients, yourselves and colleagues in terms of their mental health problems. You can use the advocacy way, you can use the collaborating way, you can use the problem-solving way, you can use the instructor way, so instructing, and you can use the encouraging way or the empathizing way. And all of these modes work interchangeably. So I cannot imagine at any one given point me being in the clinic not using all of these modes, some a lot more than the other, right? And that is okay if you do, okay? So what are some of the strengths for the collaborating mode, all right? So this is, the therapist involves the client in decision-making, reasoning about therapy, and encouraging autonomy, all right? So the strength emphasizes autonomy, freedom, and choice, and likely to inspire confidence in clients. Cautions are, this may be overutilized, and clients who see therapists as experts may not take an active role and can be misjudged. And we see that a lot in our clinics, right? Empathizing mode. This is technically putting yourself in the shoes of your patient, or putting yourself in the shoes of your colleague, or putting yourself in your shoes, in your actual shoes. I guess sometimes as clinicians, we tend to really be at the forefront of caring for others a lot more than we care for ourselves, to the extent that we forget that we also need care. We also need TLC at some point. And it's important that we also we empathize with ourselves too, right? So some of the strengths of this can facilitate a strong therapeutic relationship, can provide strong emotional healing, can disarm reluctant, critical, negative patients. But what are the cautions for this? Can take time away from active doing. So a lot of times when you empathize with people, they want you to do a lot of, their treatment for them, for example. And it can place emotions to the foreground and slow other therapeutic activity. So the encouraging mode, this is where the provider works to bring hope, courage, and will explore different activities, okay? What are some of the strengths of that? It's open and generous with expression of emotion, can project high positive energy and optimism. And some of the cautions to take while doing this is clients may become desensitized over time and not respond as expected. Some clients may interpret therapist behavior as belittling, insulting, or even foolish. And this we see a lot of times when you're dealing with stroke patients, for example. So there's so many times where we want to, really encourage our stroke patients to the extent that they start to feel that, you're overdoing it, okay? So cheering somebody on, for example. So those are some of the problems that you can get. Instructing mode. This is usually the mode that I've seen a lot of times in different clinics where providers or healthcare providers take a lot more of an instruction mode of therapy. And therapists here emphasize education and utilize teaching style of interaction. The strengths are great. So it's highly beneficial conduct of PT, OT. There is always need for some structure, transfer of knowledge, and need for feedback for therapy to occur. It's excellent at teaching and communication, convey caring and hope through investment of clients' performance, and it's organized and systematic. Overutilization or inappropriate use it comes because it's used all the time, driven more by outcomes of a process and aimed at positive outcomes. And it may not react well to clients who are not doing as required, right? Now, problem-solving mode. This is one of my best approaches to therapy. And this is therapists who favor this mode use reasoning and logic in their relationship. So clinical reasoning, which is an element that we like to teach a lot, all right? So we are looking at clinicians here may be highly talented technical thinkers, expertise in use of certain devices, theory-based approaches, evidence-based practice, skillful modification of environment, and other adaptations. Ideally, this is the clinician you should be targeting to be, all right? Very problem-solving in ways of how to address some of the things that you go through on a day-to-day basis. So the strength of this is efficient, self-discipline, and straightforward. It's solution-oriented. It's likely to resolve interpersonal differences without drama. Clients likely to maintain professional boundaries. And some of the cautions here is there's a risk of assuming an expert stance and ignoring interpersonal needs of clients. And some clients may see this approach as intimidating and too strict. Okay, so what are some of the difficult behaviors that you'll tend to see in your clinics? And this can be also behaviors that you tend to see in your colleagues when they start to have mental health issues. So manipulation, right? We've had so many times where so ideally it's seeking to fulfill social, emotional, or material needs at the expense of the provider. So some patients tend to manipulate providers or healthcare providers, right? Pretending to be sincere, so cordial, etc., to meet immediate need, but harboring negative feelings like aggression or judgment, applying lies and distorted stories to coax provider to act in specific ways. Okay, so manipulation is one of those behaviors. So we have excessive dependence, where we have some patients who tend to only do exercises when they're in your clinic, all right? So they tend to depend so much on the physiotherapist to help their symptoms go away, all right? So Another element here is symptom focusing. So sometimes you have symptom focusing involves giving great deal of energy, time, and physical effort to one symptoms instead of putting the energy, time, and effort into adaptation to enable activity performance. And it might manifest in spending excessive amount of time discussing limitations or symptoms. Symptoms become worse with stress, but client makes no effort to reduce the stress, right? And sometimes our clients have they become helpless when challenged to do something because they focus so much on their pain or whatever is bothering them. So resistance, you can face resistance whenever you're treating patients. And as an example is, if you're a young clinician in Africa, you're more likely to face resistance from the older patients that you tend to see, all right? So sometimes your patients may withdraw or avoid some particular activity. They might become hypersensitive due to interpersonal experiences that come from the past. And the fifth one is emotional disengagement. So a lot of times we as clinicians have seen patients where we tend to try to really bring the best out of them, but they feel like they're not interested in the whole process of therapy, right? So denial, this has happened so many times in clinics where patients are either diagnosed by a particular condition that is evident and is seen in how they are presenting, but the patients do not want to admit, right? So denial of reality of an event. Admit an event occurred, but denied its seriousness, for example, and acknowledge an event happens to others, but does not admit the event also happened to him or herself, right? And you can use collaboration and empathizing modes to help these patients as well. So difficulty with rapport and trust. Rapport and trust is very important to building a relationship with patients. And it is by building this that you tend to have better outcomes in treating your patients, and also better outcomes in patients kind of like opening up to you. A lot of times you develop this as you continue seeing your patients. It automatically, as humans continue to interact, they automatically tend to be open to one another. Hostility, and I believe some of us clinicians have experienced this, whether it's in the clinics or whether it's a house call. So behavioral expression of rage or anger, making threats to harm or make providers' life difficult. So this sometimes happens a lot with patients who have dementia or other degenerative brain diseases, the older patients especially. And sometimes they can say things that belittle, humiliate, or harshly criticize or trap the provider. And then therapeutic responding. This differs from non-therapeutic responding, which we have seen in the previous slides, in terms of emotional reactions that the response is likely to produce in the client. It's consistent with principles of interpersonal relationships, and the process of therapeutic responding encourages providers to be systematic and self-disciplined in deciding what to do or say when faced with problematic interactive events. And some of the respondents or potentially non-therapeutic responses are parental responses, defensive responses, patronizing, use of cliches, minimizing responses, or prematurely optimizing responses. And you don't want to use some of these responses here with your patients, your clients, or your colleagues, all right? We have dismissive responses, withholding responses, evaluative responses, but you can also try and figure out which of these responses will be useful for you as a clinician at that particular time. So what is interpersonal reasoning? This is me almost coming to the end of the presentation. It encourages providers to engage continuously in the process of interpersonal reasoning. I'll compare this to critical thinking when deciding how to interact with clients. So interpersonal reasoning involves 6 steps which are you anticipate, so holding expectation of likely interpersonal event, identify and cope, accurately identify and label the event, prepare and cope with it, determine if a shift of mode is indicated, and you choose the response mode from the modes that we have talked about. And you need to also draw on relevant interpersonal skills associated with the mode. And then you gather feedback, always gather feedback from your patient. And that brings us to the end of our presentation today. And I think we can open up for questions and answers. So thank you so much for bearing with us despite the technical hitches, which usually happens. Hopefully they won't happen again as we present in the future. But yeah, let's listen to your questions and also have some interactive space. Thank you so much. This is Martin and I'm done speaking.
Thank you so much. Hello? Hello?
Yes, Aaron.
Yeah. Thank you so much. Agnes, your sound is breaking. Hello, yes, thank you so much. This was quite interesting and a good session. I can see we have some raised hand. I would like to welcome JD if you want to pass on a comment or a question. Then you can Rwanda myself. I'll ask you to unmute us. Please unmute and ask.
Alan?
Yes?
That's not me raising the hand.
Okay. It is someone else called and I'm inviting them to ask if you have a question, but they are not unmuted.
All right.
Yeah, this was quite a nice session. We have a few questions. If you have a question, please write it down in the chat box below. And if you want to ask in person, you can also raise your hand up. Yeah. Yes, Mr. Coleman as well. You can ask. Hello? Hello?
I think we can go ahead with someone else.
Yeah. I think we'll get one of the questions in the chat box below. There's a question that was about that most of the clients have received social and spiritual disturbances because of joblessness. I think the presenters talked about this while presenting, but we can also give them time to explain more about this and how people can overcome this, although they explained it because it was one of the comments in the chat box below. Yeah. So I'll welcome Shadrach to answer this and throw more light on this. That says that most of the clients have received social and spiritual disturbances because of joblessness or because of losing their jobs. Thank you.
That's a very difficult question, and in the essence of it totally depends on the dynamics of the country that most of the clients come from, but also we as clinicians, it's very difficult that we're going to be a source of funding for our patients, or we're going to provide some sort of financial support for our patients. But that said and done is we can be at the forefront of involving our governments or involving the persons in the hospital who are in charge of the social responsibility of the systems we live in, where we can highlight the need for wages, job creations, because we see a rise of mental health issues in our clinics. And some of the patients that we've seen, they don't necessarily come in to the clinic because they have neck pain, and because that neck pain is causing some sort of tissue damage. They come into the clinic because of all these other factors, health, and these are some of the social determinants of health, like a lack of money to do the things we need to do on a day-to-day basis, stressful situations at work, stressful home environments where they're experiencing abuse and all that. It is, we may not, as clinicians, change those social determinants of health directly, but we can be responsible in ensuring that our patients don't come from anxiety, depression, to finally becoming suicidal in thoughts, all right? We can help address that, but also we can be advocates of change for our patients, in the essence that we will have to get involved into policy making for us to address some of those problems, all right? And that is just my point of view, but I can let Shadrach as well to chip in that perspective. Shadrach.
Okay, thank you, Martin. And I think that's an elaborate answer based on what we are facing now, and as people, as a community, and as professionals. And ideally, the key thing is me as a clinician and you as a clinician, if at all we are in position to understand that, yeah, this particular patient, apart from the issues that they are coming in with, either musculoskeletal or something else, there is something accompanying that becomes great. And then now from there, as just Martin has said, that we need to be vigilant as clinicians in terms of screening them, yes, but we need to see how are they going to get help. Some of them have no funds to get to see the mental health providers. So that's now where the government has to get in. But the government can only get in if we, as clinicians, have the know-how of what is going on the ground. Yeah, thank you.
Thank you so much, Shadrach and Martin. There are no more questions in the chat. I don't know if they're exhausted, but I have a question regarding mental health still. So you find that there are people that have like depression due to various reasons, and maybe there are different classes, I think, that help them fight against the depression and those sorts of things. So for example, like joblessness is inevitable, or let's say losing someone is not something that one can control. So for someone that has that kind of depression, what can someone do to help them start to get out of it or be able to live by it? Yeah. Hello?
Hello. Yeah, I hope you can hear us.
Yes.
Patients with depression can be treated in physiotherapy clinics, especially clinics that have some sort of specialty in addressing depression in itself as a state. So our role, ideally, as we speak, is to help clinicians to be able to detect and be able to prevent our patients from getting into just a chronic pain state, into a depressive anxiety state, all right? But once they get to the depressive state, we have a questionnaire that we have used over the years in the clinic that we had to adjust. So the questionnaire was called the PHQ-9 questionnaire, where there was 3 questions. The first question was, are you depressed? So I would ask Shadrach, are you depressed, Shadrach? They say no. And if you ask an African if they're depressed, that is war in itself. That is, I lost a couple of patients just by the fact that I asked them that simple question. So the second question was, have you lost interest in doing things that you used to do? Or have you lost an interest in doing certain things in your life that you used to do that you loved? And it is out of this question that a lot of the patients really opened up and started to tell us, that they're depressed, they're in this type of mood. And we did use the wellness recovery action plan. So we told them the wellness recovery action plan. I think what I'll do, I'll pass that document to Jean so that he can share it with all the clinicians who have attended the course. Is the simple strategies that, first of all, can help them to determine what are some of what are some of those issues that are causing them to be depressed. Because there's a list, and depression is almost like you never really know that somebody is depressed because they don't look sick. They don't look like they're sick people, right? But there are certain things that have been piling up in their life that have driven them towards that direction. And if we can address some of those things, and as I mentioned, some of the health determinants and social health determinants are very difficult to address from a clinical perspective in inpatient clinic. But there are certain aspects, and I think Rwanda has been very keen in introducing all the different aspects of healthcare and social provision of different amenities to help clients and patients survive and cope. And those are some of the strategies I think myself as a clinician from Kenya, I would like to learn from the Rwandan team, all right? Because you guys already have strategies and this was built out of the adverse effects that happened during the genocide. So there are a lot of good social provision of different extra amenities that help patients cope with some of the things that they undergo. But depression, physical activity, exercise, meditation, solving the things that are causing the depression or the depressive state of the patient can help a lot. And sometimes even just listening, providing an ear. When you listen to your patient stories, when you try to show them that there are different coping ways or different mechanisms to cope. And physical activity and exercise is on my #1 list in terms of helping with that. Sometimes nutrition is, but sometimes you don't know why your patient has got nutritional inequalities. It could be something to do with, I cannot afford it. So it's very difficult to pinpoint a direct answer to helping a patient who already has had depression. It is very individualized process of treatment. But if you can use the wellness recovery action plan, you'll be able to address most of the problems that your patients are coping with. And sometimes I think one thing I forgot to mention is that in the PHQ-9, there was the element of if you at any given event ask your patient if they're depressed and they said yes, there was another question that said, do you feel like you would want to harm yourself or any other person in that matter? And if the answer was yes, then that involves that start to take us in the direction of involving, security personnel, for example, because that is a patient who may take their life and the life of another person. And in Kenya, we've had that. So when COVID-19 came around, we've had a lot of police officers and even people living in their homes there was an increase in domestic violence. And the domestic violence was because of the social tensions that were happening in the homes, to the extent that if I can provide for my family, why should they be leaving? Because those are some of the conversations that some of the patients that we saw were bringing up. I don't want to be alive and I don't want to watch my family suffer because they cannot provide for them. So there are different strategies that we use, and I'm sure there's different hotlines that you guys have. In Kenya, there's a few people who deal with psychosocial issues, psychologists, so we work in collaboration with them. If a patient needs psychosocial and psychological support, we will refer them appropriately. But our role as physiotherapists is to ensure that we provide physical activity and different ways of coping. And the physical activity is not just go and exercise. It's very individualized, patient-centered types of exercise to help them cope with their problems. I hope this answers part of your question. It's a very long answer, but I hope it helps.
Thank you, Martin, for that. And when you look at Martin's answer, is kind of making you as a clinician, not just as a technician. And basically, most of the time, clinicians on the side of physio, we have been doing things like technicians in terms of this is what you need to be doing for this particular patient, and you move in and the patient have got, for example, neck, and this is a neck pain patient, and I'm going to follow the procedure of like kind of a sequence or a ritual you perform in a clinic to help that patient. So basically for us, I mean, the key and the super important thing, even before we move to how to help a patient with depression, is are we able to fish out, or are we able to recognize that there's some psychosocial problem happening here, and that's what we term as yellow flags. So, and as he said, yellow flags sometimes can be red flags. So, and if you get a patient who is talking about suicide, then that's a red flag, because you need to get more help. You need to find a specialist who can take care of this patient, and you need to refer this patient immediately, because he's a patient that can be able to take his life or take somebody's life. And we also get patients that kind of overrate things, and they do say things that actually, when you correlate, it's not exact. So they kind of symptom catastrophization, they kind of overrate things. And these are some of the psychosocial measures that we need to be fishing out. And we also need to put together kind of psychometric measures, the forms that you need to use to screen all these patients. And then from there, the way forward. And even sometimes patients come to us, we don't know why they are late. Sometimes, I don't know, here in Rwanda, the patients come to the clinic late. Sometimes where we work, you'll find such happening, but sometimes you as a physio or a clinician on your booking, you're going to be angry and say, maybe he's keeping your time, but we didn't know why he's late. We don't know where he's coming from. We don't know if he has got maybe like the prior question of that he has the financial support to make sure that he is coming to the clinic and he's able to pay the the kind of the transport. So all these are put together in terms of psychosocial perspective, and we need to be vigilant on that. But at the end of the day, we need to work in collaboration. Apart from what we do as physiotherapists in terms of dosing specific exercises based on what they have, we also need to understand that there's another, we have got mental health specialists that we need to work hand in hand to help these patients. Thank you.
Thank you so much. That was such a detailed explanation, but at the same time, very nice and detailed. It helped me understand a lot. I do not see any more questions from the participants. No hands raised up. No questions in the chat box. So I think maybe everyone has understood. I don't know if JD has a comment or anything that you'd like us to know. Then
Okay. Alan, thank you very much. I'm very happy at least we are able to, excuse me. Okay, I'm very happy that we are able to get this kind of presentation, and for healthcare providers joining in this event. I mean, those ones being in Rwanda or in Kenya or in another country. So it's a very good collaboration between these therapists together with Health-Edu National Research Foundation. So we're going to be organizing such events, and then we would like to invite them for next time so that they may be more active in raising up issues and for example, what's the situation of mental health? If some of the therapists are working in public or private hospitals, do you get enough time? Is there any support? I mean, mental health support that is provided by your institution, and so many other issues that can be raised around the topic, as everybody is overstretched to support and contribute towards the response on COVID-19. So we're going to be organizing such events next time as well, and under the support of the National Research Foundation. And I would like to thank everybody who have accepted to join, and thank as well the presenters for their contribution and willing to deliver a good presentation like this, and then enabling a discussion. And for the members, I mean, for all the audience and participants here, the materials are going to be uploaded on our platform, on Health-Edu platform, so you'll be able to access them, and you will be able to get a certificate at the end. So I would like to thank you, and maybe over to Alan. Thank you.
All right, thank you so much, JD. I would like also to thank the presenters that have really given us a detailed and well-explained session. We really learned a lot. I can see there are so many comments in the chat whereby participants are requesting for the presentation. That means that they really want to take a second look at it and go through and really learn a lot from it. Yeah, so thank you so much, Mr. Martin and Mr. Shadrach. Thank you so much. Yeah, so for the presentations from the participants, that want them, please, you'll be able to get them from the Health-Edu platform as usual. Agnes will send a link in a few minutes. You can copy it with the Health-Edu platform, and then you can be able to get the different presentations, especially this one from there. Yeah, thank you so much. I would also like to thank the different participants for attending. Although we had some disconnections from both our sides and from the participant side, especially unmuting the microphone, but it was a nice session, and we'd like to thank everyone that participated. Thank you so much. If there is nothing else, we hope to see you next time for another session that's coming.